probably with anything we have here in the United States, had to more than double its critical care capacity across the entire region of Lombardy, Italy, and filled the hospitals entirely and crowded out all sorts of other healthcare needs that couldn't be provided for because the hospitals were filled with critically ill folks with this new and unspecified disease. So if you remember back to that time, I had just become a health commissioner on February 10th. And March 6th, 2020 was the day we announced, a Friday, our first COVID patient in Kentucky. There was so little we knew, or said differently, we knew almost nothing. We didn't know how the disease spread. We had speculations, and you could say it was a respiratory disease, but there's a lot more nuance and detail that matters. We didn't know how lethal it really was. We didn't know how many people had it. We didn't even have access to testing. So at the time, for all of January and even much of February, only the CDC could test for this. And then state health departments could test, but you remember that there was a miscue with the specimen kits there were three components to the testing process that were sent out to the state health labs, and one of them had a problem. And so that delayed us a bit. And so as I was doing press conferences and dealing with this in March, the ability to test was incredibly limited. You could test people, you had enough testing to test people you were specifically concerned about, but there was no testing to be able just to test everyone who was concerned, right? And so then we had to rapidly build up a whole new testing infrastructure for one specific pathogen. I mean, so this was building whole delivery systems to test for one disease. And we went through periods where there were not enough chemicals, there were not enough plastics, the plastic trays were in shortage. The pipette tips, we still have problems with that. Certain pipette tips for these specialized machines to do PCR testing are still not as abundant as we need them to be. So we went through that whole journey. And you remember, no PPE, right? We didn't have enough N95s. We didn't have enough gowns and gloves and masks. And here's an example where this incredibly interconnected global network and a supply chain was a real liability, right? Because so much of the manufacturing for this PPE is done in the Far East and in the other side of the globe. And where was the first place in the world to get hit? The Far East, right? So the very places that we rely upon for manufacturing are the places that were getting hit. And so those supply chains got disrupted. And then when the entire world is facing the same infectious disease threat at the same time, the demand surged, right? So everybody needed the same stuff at the same time, and the people who were making it were not able to make it or export it, and quite frankly, needed the materials themselves in a volume that they previously didn't. So you talk about the lack of ability to test and identify people who have this condition, the lack of the ability to protect the people who are clinically exposed to this as clinicians caring for these folks, the fear of the unknown, and the concrete evidence of real things having happened in China and northern Italy, where this came up, and the tsunami metaphor really is apropos, because it's not like a tidal wave just overtook you and swamped your boat. It really is like the tidal wave swamped you, and then a wall of water keeps coming unrelentingly, because once the first patient shows up, you know that until you exhaust that reservoir of infected individuals, they will keep showing up in continually elevated numbers day after day after day. And I don't think that's apparent to folks all the time. Most hospitals run at fairly close to capacity in normal operations. And when you start having an extra 10 and then 20 and then 40 and then 80 people show up, and they don't go home quick. The average length of stay was 8 or 9 days back in the early part of this pandemic. They don't go home quick. So the hospital keeps having more and more show up, no one going out the other side, out the back door, and the places run out of room. So we went through all of those journeys, and we had to scramble and compete state by state to get PPE as much as we could. There's some outlandish stories about the types of fraud that people tried to propagate, what they were trying to sell. counterfeit masks, price surges that were absolutely incredible. Products that would cost less than $1 a piece now cost, people charging $6-7 a piece for certain types of PPE. A textbook example of supply and demand, where the demand was so high, the cost went up exceedingly. So all of those things, and for the first time in the history of the United States of America, the United States federal government and all 50 states declared a state of emergency concurrently. All right, that's how bad this was. And people who don't normally get scared, people who are accustomed to making high stakes decisions, high level elected political leaders, and people who report to them and advise them. I don't want to say no one was scared into incapacity, but people were very, very worried about the harm that could ensue, because we'd seen it happen in multiple other countries. And then it happened in New York. And so the picture, this still impresses me in a sad way, that the whole image of having white tents in Central Park in New York City, providing care, complex medical care for people in tents in the middle of Central Park, hasn't left more of an enduring image in our shared national psyche that this is a big deal. Like, this is scary. And that there's a real danger for a lot of people to get hurt. And also, I guess you could say it's testimony to human resiliency, but it's also a difficulty when our memories are short, and we acclimate to the new realities. There, as we talk today, there are more than 2.4 million people who have died globally, approximately or close to 500,000 Americans in 12 months, and over 4,300 Kentuckians. And to put that into context, this pandemic, COVID-19 in the United States of America, was the third leading cause of death in the United States of America in 2020. So something that did not exist in 2019 became, in 1 year, the third leading overall cause of death in 2020. And by the time we reached January, we had 3,000 or more deaths per day in the United States of America from COVID. In terms of the number of deaths per day in the country, it was the leading cause of death in January in the United States, having overtaken both cancer and cardiovascular disease, which are then otherwise number 1 and 2, or number 2 and 1, I think is the order, causes of death. And so this is a problem of staggering enormity and real danger, and incredible complexity. And it shows, as you look at your case study that you'll do, I have to emphasize this as you work on that, you cannot possibly over communicate in these kinds of crises, because no matter how much you think you have communicated, it has not been enough. That people's need to hear things not once, not twice, but if it's correct, the general term or sense is 7 times for things to stick. And then our difficulty with fast changing situations where the information and our knowledge was changing rapidly, often week to week. So the guidance was changing sometimes week to week. People get very frustrated with that because they never have a chance to understand what they've just been told before they're being told you have to now understand something different and do something different. That's very, very hard. It's very difficult for folks to move that quickly. Just a normal part of the human journey, but it's a difficult part when you're trying to message through a crisis and continue to have folks feel comfortable and reassured that people are attending to their needs and trying to keep them as protected as possible and trying to communicate as quickly with accurate information as is functionally possible. And it's very, very difficult because you have to build tracking systems that didn't have to be there before for circumstances that didn't exist before, using technology that's often 2 or 3 decades old in terms of software, and doing it with a workforce in public health that has unfortunately for a long time been under-resourced and underappreciated for the important role it plays in a lot of areas, but in this case, in infectious disease control and protecting us from these kinds of problems. So it has been a really remarkable journey to go through that, and it has direct implications for the case study that you're going to do. So let me give you an update for where we are now, what the outlook might look like going forward for the next 6 months or so. I'll try to tie this in then to your case study a bit. And then I've been sent some questions that people had pre-submitted. I will say, Joel, I'm not bashful, and there's nothing that I'm not uncomfortable handling anything. So as we go on here, I'm also happy if this doesn't disrupt you too much to respond to questions if people put it in the chat box too, if they have that functionality.
Yeah.
So I'll do that as well. But so where are we now? We are exiting the longest and biggest surge we've had in the entire pandemic. We are now exiting that. In both in the state of Kentucky, nationwide in the United States, and even for the most part globally, disease rates are diminishing rapidly. And so you might say, why? I'm not sure we're entirely clear why. I think parts of it have been, we went through the holiday season, almost certainly people gathered and did things that we asked them not to do. Almost certainly they got together in more frequency in small settings to eat and drink and celebrate together, frequently without their masks on. So that almost, and there's cold temperatures and people are indoors, not outdoors. So almost certainly that contributed to some of the surges we had, certainly in the United States and in the Northern Hemisphere. Additionally, exponential growth is a really difficult concept for the human brain to get its head around. When you only have 1 or 2 people with disease, if it doubles, it becomes 2 or 4. So I've said this before at a press conference. 1, 2, 4, 8, 16, that's a sequence of doubling numbers. They're small numbers and all of us can relate to it. There's 85 people in this Zoom session and I just got to the number 16. Well, if you start with 1,000, 2,000, 4,000, 8,000, 16,000, those are a lot bigger numbers and those are harder for us to kind of get our head around. When you talk about nationwide or globally, and now you're talking tens of thousands or hundreds of thousands or millions of people with cases, the numbers get big really, really fast. And so part of the challenge is in Kentucky, we've had 3 surges of this disease. We had it in March, we had it in the summer, and we had it in the November, December, early January timeframe. In March, in all 3 times, we effectively stopped it. We did not reach a plateau this 3rd time like we did the last time. We went up and now we're coming down. The other 2 times, the actions we took resulted directly in a plateau. And I feel very confident about that, seeing how this has unfolded in other jurisdictions and then how it unfolded for us. When we ratcheted up the measures and took the steps we did, in the spring, you remember we had Healthy at Home. And like many other states, we shut down as much of our interaction with each other as possible. We stopped that exponential climb right where it was, kept it flat, and then we stayed at a new plateau. And that plateau lasted a few months. And then we started climbing again in the summer. We were worried about the 4th of July and the summer kind of holiday activities. And we started to have a climb in July. And then we imposed additional measures and we stopped it again. And we had a plateau for a number of weeks. And when you look back on the epi curve for this disease, you can see that we had a plateau. When we got to the winter, we were at a much higher plateau though, which meant when we started to take off exponentially again, you had a lot more people who were going to be infected very quickly. And so then we started to surge very high. And that's when it sort of, if you had a map of the United States of America, it started at the coasts. It kind of came down to the Sun Belt, the southern states, and up kind of the desert in the west. And then it sort of reached in and came into the Midwest, which is where we are. And so that's kind of how this happened. But at the same time, you could see some other places have a second surge. So Louisiana had a second surge. Arizona, I think, had a bit of a second surge. So if you take your eye off the ball, it's kind of like we had seeded the entire nation with disease, and it was all now embers throughout the whole country. And now it's just ripe for a major escalation. So what we have to hope now is that the disease is receding a bit. And I said, remember that I don't think we completely understand it. Although who knows? I mean, maybe there's reason to be cautiously optimistic that enough people have been infected, not that they were anywhere near herd immunity, the danger's not gone, but like a nuclear reactor where they insert cooling rods between the active rods to try to slow the frequency of the reaction. Maybe there's been enough people infected to begin to slow a little bit the unrestrained progression of disease. But these mutations and these variants, of course, raise a serious threat and concern. So, these viruses mutate regularly. The vast majority of these mutations are inconsequential, but every now and then, sheer luck results in a mutation that gives a competitive advantage to the virus, makes it either more transmissible or more lethal or both. And in this case, we have examples of all three of those, right? So that we shouldn't label them by country, because it's not as if it's the country's fault that they occurred there. There are almost certainly variants here we just haven't found that may have competitive advantage in our own country. But the British variant, the South African variant, and then the South American variant, the Brazil variant, two of the three of those, the UK and the South American variant, are more transmissible, it appears, but maybe not more lethal. Although there may be some question about the British one, about if it's a bit more dangerous. The South African one was shown to be perhaps more lethal to the individual who gets it. And again, when I go back to the communication point, this is where it's difficult with when you're communicating at scale across the entire public. There are two different ways that these diseases can cause a lot of harm, right? One, it infects a lot more people, so it still kills 1% of the people, but now if you have 10 times more people infected, there's 10 times more death, or 10 times more hospitalizations. The other way is you have the same number of people infected, but it now kills 10% of the population, not 1% of the population. So you can get to the same end result two different ways. And the worst of these combinations is, of course, it spreads more rapidly and is more lethal. And then you have the worst of both worlds. So where we are right now is, for the moment, we appear to be having a recession of the current surge. And that's good. That means most places are finding their hospitals are no longer strained. The number of cases is not nearly as many. The number of deaths is, that's such a lagging indicator. The bigger numbers now are still in many ways a consequence of what we had in December and January. But as we go further along, we'll see those numbers decrease as well. And I think what we have to be hopeful for is that the number of people who have been infected helps to slow the further progression. Obviously, the vaccines will hopefully help slow the progression. And then the warmer weather will hopefully help us go outdoors more. We're not warmer this week, but we'll be here in just a month or so. We'll be into the early part of spring. And then hopefully people are outdoors doing more outdoor activities, outdoor dining, outdoor social events will be more possible instead of indoor stuff. And so hopefully the combination of all those three things, hopefully, will keep us from having another major surge in the near months ahead. Now, as far as the vaccines, of course, we have the Pfizer vaccine was first available December 14th, the Moderna one a week later, about on the 21st. And then now the Johnson & Johnson vaccine would be the third one that's going to be reviewed by the VRBPAC, which is the FDA's committee that deals with biologics, and that'll be on February 26th. I think most people anticipate it will be approved. And if that's the case, then apparently small quantities, but there'll be some quantities probably the next week, and then they have to scale up their production so we have more access. If all of these vendors are able to provide the vaccine in the quantities they say they will, it should be by the time we get to the end of June this summer, everybody who's wanted to be able to be vaccinated will have the chance to be vaccinated. That doesn't mean that all the folks who are hesitant will have been vaccinated yet. It means everybody who's eligible and interested will have had the voluntary opportunity to get vaccinated. So we have to maintain our optimism, because as long from now as that may feel, you're really only talking 4.5 months to the end of June. And so this is going to change very quickly. In technology, people talk about an adoption curve. You have the early adopters, the main adopters, and then the laggards who adopt at the end. We're going to go through that whole curve in the United States for vaccine deployment in about 6.5 months. The problem is the tail end of the late adopters could be a substantial population where we have to hope they come to a position of more comfort and are more willing and open to getting vaccinated for their safety and for everyone else's. A word on the vaccines themselves. They have been shown to be highly effective at preventing severe disease. So think death, hospitalization, kind of severe disease. They have been shown to be effective, but not the same effective from preventing you from having mild to moderate disease. And I would probably describe moderate disease as like a bad case of the flu. You feel really crummy. Maybe you're laid low for a few days or at home and you can't go to work. But it's really the severe disease when you end up in the hospital and in trouble. And so all of these vaccines, all three of them, have been shown to be effective preventing severe disease and death. And so if it were me, I would take any one offered to me. The newest one, the Johnson & Johnson, has the great appeal of being a one-dose vaccine and being stable at refrigeration temperatures, which in addition to making it being a very effective vaccine, also makes it a very appealing vaccine because it can be used in a lot of ways the other two can't, because of their storage characteristics and their perishable nature. It's interesting on the vaccination front. The intensity of demand right now for people who want it, who can't have it, is extreme. And that's happening at the same time where the intensity of apathy in another portion of the population, who I would say are not opposed to vaccination, they just want to be more persuaded. They want to see that it's safe and that it's effective in more people before they seek it out themselves. But we, for these vaccines, the demand is so extreme now that in the early weeks when we started announcing a few weeks ago more sites, people would get as many as 600, 700, 800 calls per dose of vaccine they had available to schedule. And so I think one of the large chain pharmacy stores said it crashed their national network when so many people were trying to schedule at the same time. And so we're going to have this ongoing challenge for at least another month or more, where that intensity of demand is that extreme, before we get to a point where it's more prevalent and available for folks. I think by the time we get to the summer, though, with the warm weather and everyone being vaccinated, who wants to, hopefully we're in a much better place. And then the challenge becomes persuading the population that it is still important for a period of time to wear masks, to socially distance, and to still do all the public health measures, because until all the vulnerable people have had a chance to be vaccinated, they are still at substantial risk of major harm. And until we vaccinated enough people, the risk that variants and mutations could still propagate, and we could have one that learns to be more effective and undermines the efficacy of the vaccinations, is significant. And so we have to remain vigilant in this. So let me tie this in real quick here to what you're doing in your case study. Some of the things I've observed, I've already shared, but science is amazing. Okay, we sequence, as a human species, we sequence this genome of this virus like the first week of January. All right. So I don't know how many people here are old enough to remember when they were talking about sequencing the human genome, and it took like years. It was like a worldwide collaborative effort taking years to do. They sequenced the whole genome of the virus, within a matter of weeks. And now for surveillance here, even in the state, we sequence the genome for a subset of the samples that test positive on a regular basis here at the state. Now, we don't sequence thousands and thousands of specimens, but we do sequence hundreds of specimens. And so just the thought that now that can be done in a state public health reference laboratory as part of routine surveillance is really impressive. Prior to the COVID vaccines, remember, we had COVID vaccines in Kentucky on December 14th. Pfizer was here for us to use. March 6th was the first patient we had. So you're talking about 10 months. So from the time we identified our first patient here to the time we had a vaccine that was really highly effective, 10 months. Prior to that, I think the fastest commercially developed vaccine was for mumps, and it took 4 years. Now, a lot of this had to do with the federal government de-risking the pharmaceutical companies, meaning that they were able to start producing vaccine concurrent with the research, concurrent with the approval process. Normally, they would never do that because if it was not approved, you'd throw away hundreds of millions of dollars worth of manufactured goods. The federal government took on that risk so that they could work in parallel. And so I think there were really some good things that were done last year to accelerate that development that really didn't curtail the safety of the products. They just did what a big government should do, is assume the risk that's not bearable for the private actors in that situation. So science is amazing because we got vaccines faster than ever before in human history. We have technology to do the testing in ways we haven't done before. That's really cool. Public health emergency response is like really complicated. So as I looked at your case study, I couldn't help but think what I would write. So I did my business degree a few years ago. I got my MBA. And so business school case studies look just like the exact same format you have here. And what I would write down theoretically and what the real world experience of this is are not necessarily the same thing. And so you never have enough time. So let me just tell you that. You always have tasks that have to be done last week. And you only have so many people, so many hours in the day, and so much cognitive and emotional reserve, and you still have to find a way to get it done. There's usually, I wouldn't say always, there's usually not enough resources. So, and that could be for a variety of reasons. We didn't have testing because testing didn't exist for this at the time. That's not like someone just didn't give you enough money. The testing didn't exist. You may not have enough people. You may not have PPE because there's just not enough manufacturing capacity. And for N95 masks, I would have been happy if we could, but a state government can't do this. I would have been happy to take the patents from 3M and Honeywell and say, we'll take your patented material and we'll make it. But you have to have specialized machines and a whole lot of advanced technology to manufacture those things. You can't just do that overnight. I'll give you a different example. We didn't have enough hand sanitizer. Well, the distillers in Kentucky, a number of them stepped up. And so some of you may have seen the bottles that have your popular bourbon name on the front of it, but it's not bourbon. It's alcohol that is either just alcohol you can make into your own sanitizer or sanitizer produced from distillers alcohol. And so we had places, the prisons started to make some masks and some gowns for the state prisons. Some of those things you could manufacture to a sufficient quality to use. N95 masks were not one of them. You often don't have enough resources, and wishing you had more does not make it so. And so you have to figure out a way to function despite that limitation. I've already told you communication is key, and it's inherently imperfect. Communication, it takes a lot of repetition for people to assimilate what you've told them. And when the information keeps changing week over week, it has the undesirable impact of sometimes undermining confidence in the information instead of having people feel that you are being transparent and open in real time. Those are real challenges because you always want to be candid and transparent, and you want to be honest. You never want to candy coat stuff beyond what the reality is, but you still have to balance that with not inspiring mass fear and hysteria at the same time. I don't think any of us are worried that right now there's going to be mass fear and hysteria about COVID. In March, I don't think that that was the case. In March, when this was just starting, people really had no idea what was going to happen. No one did, not the decision makers and not the people at large. And we all had to do the best we could to work our way through that. So communication is challenging, but it's so important trying to calibrate and balance those two different needs. One, always to be open and candid and honest, but also not to inspire fear rather than inspiring confidence and security. Another thing, now I teach in a business school, and when I talk about some of these things for communication, is a lot of times different types of communication is masquerading as something it is not. So there's one thing when you're sharing information, there's another thing when you're trying to persuade, and there's another thing when you're trying to misrepresent things to get people to go down a different path than they are currently going down. Those are all very, very difficult. And so I think all of us have to continually learn how to be more critical receivers and interpreters of the information we receive. And I will just say, just in passing reference here, all of us need to be more careful about not locking ourselves in social media bubbles and cable news network bubbles. And I don't care what political persuasion you're in. It's not good for any of us to get stuck in these echo chambers where we are constantly insulating ourselves from the opinions of people who see the world differently than we do, because we disadvantage ourselves and them if we do that, but also where we start to see other people who disagree with us as the enemy instead of someone who has a different opinion. It's not the same concept. There's a quote that that stuck with me from a book written by, well, it was an interview with Robert McNamara, who was the Secretary of War during the Vietnam War, and Secretary of Defense, rather, whatever the title was. I think it was Defense or War, and time of war is probably war, but Secretary of Defense, I think, is the term they use because we never declared war, perhaps. So Secretary of Defense. Forgive me as I think through my American history and figure in my U.S. federal government structure. So McNamara was Secretary of Defense, and he talked about the Cuban Missile Crisis and how we almost had nuclear war between Cuba and the United States. And there's one of the book title chapters, or one of the chapter titles is Rationality Will Not Save Us. And so I want to caution us all that when human beings interact in large numbers and at scale, you can't rely on logic. You have to think through the psychology of how people behave in large groups so that you communicate and you lead attendant to or aware of the way people behave in large groups, which is different from two people having an intellectual discussion over a cup of coffee in the college library. That's not the same kind of discussion that happens when you're trying to lead a population of millions of people or tens or hundreds of millions of people in a time of uncertainty and frustration. I'd encourage us all. I know here that I think science without some sensitivity to the humanities really fails to reach its full potential. So people have to be convinced at times, and they have to have trust in folks. And to the extent you are aware of a broader array of things than just the science, you can connect with them in a place that they're more familiar with, use examples and stories with which they resonate, and you can help people to feel comfortable through familiarity instead of bludgeoning people, which has really been shown not to work. You can't beat people to death with facts and get them to do what you want them to do. Which leads to my next point is people are persuaded by people, not facts. It is really important to have leaders that people have confidence in and security in, because you really need people to have a sense of trust and belief that the folks who are charged with leading the emergency response have their best interests in mind. I can't urge this enough as I've gone through my journey of leadership experiences. We had all better hope and be attendant to um, electing, appointing, hiring, whatever the right term is, people who are fundamentally good human beings. Because at the end of the day, there is no way the average person can ever know all the information and all the facts and all the details and be present for all the decisions. And so you have to hope that you have chosen people of good character who have your best interest at heart in some way, because ultimately they're going to be making decisions that impact us all. When you do your teams, this is good in life in general, but for these projects, now you've already written your proposals and stuff, so it's too late for this, but always, always, always have the most diverse team you can find. Diversity in all sorts of domains, different backgrounds by education, by culture, by gender, by experience, whatever the domain is. Diverse teams yield better results because they're less prone to hit blind spots, less likely to miss the obvious, less likely to have groupthink where they make the same mistakes and don't recognize it. So I hope those are some thoughts. So let me give you here real quick now. Now, if you have questions, folks, type them in there. I'm going to run these questions I was given here before. It says, here's the question. It appears that vaccination efforts are not going as quickly as hoped in skilled nursing facilities and perhaps not at all in prisons. What's being done there, and can we volunteer to help? So for skilled nursing facilities, all the staff and residents were offered the opportunity to be vaccinated through the federal program with Walgreens and CVS in Kentucky. And the uptake, I shouldn't quote statistics when I don't have them in front of me, but it was over 70% for the staff. It was, I think, more in the 50% range or so. I'm sorry, it was over 70% for the residents. The residents had a very high uptake. Some places it was even higher. The staff had probably more like a 50% uptake. And I think there's a lot of work to be done for people to be reassured. I don't think these are hard no's. I think these are people who want to feel more confident, and they have a variety of different reasons. Remember, they deal with a frail and infirm population a lot of times, and the mortality there was high. They may have other fears or anxieties attendant to what their personal experience was there. As far as prisons, we have offered and vaccinated a number, again, it's all voluntary. So we've vaccinated a number of the state prison employees, the staff in the prisons, and may go to like 1B eligible prisoners as we go to 1C for the general population. So that's all part of the journey ahead of us, but they're both important populations. I will say 2/3 for most of this pandemic, 2/3 of all of our deaths were in long-term care facilities. That has now fallen to 55, 56% of all of our deaths. So what we have here is it looks like probably some combination of the vaccines has now helped us to have the mortality rate start to come down substantially in the nursing homes. And that's fantastic. There's a perception that some in the community that are not convinced, that some are not convinced to get vaccinated. What's your best approach to start a conversation with these individuals? I'll tell you, this applies to things in general when you want to persuade people. I think you have to seek first to understand and only then to try to persuade. And my approach in this is to offer people information and then try to work with people with whom they resonate. Remember, so I hope you find this engagement with me interesting. I hope that you feel that I'm behaving credibly and responsibly. But if I'm not the right messenger for you, then hopefully we can find another messenger who has been persuaded and with whom you connect. And so I think we underestimate just how much we're persuaded by individual people and our sense of connectedness to them. And so I think this is an area where we're going to just have to continue to expand the number of people who can help connect with folks and help them feel reassured. With the current and projected pace of vaccinations, when do we expect to get to herd immunity in Kentucky? I love that concept. There's the question itself is actually very reasonable and appropriate. In general use in the public, I think people think of herd immunity as some magical silver bullet. And I wish I could have their shared confidence in that, but it's more complex than that. Herd immunity is if the virus doesn't mutate, it does. Like, we've never gotten herd immunity from the influenza, right? Every year there's influenza. Every year the vaccine has to be changed, right? So herd immunity is a more nebulous concept than just what people think it is, where you just vaccinate a certain number and all of a sudden everything is gone and it's better. So in this case, most people, you say at least 70%, based on the transmission value of the virus, the R naught, how frequently it's transmitted. But with the more transmissible variants, it's probably more than 80%. So I think if we could get 80, 85% vaccinated, we'd want at least that much. But the bottom line is, by the time we get to June 30th or so, there should be plenty of vaccine in the state for everyone who wants to get vaccinated and virtually everyone who needs to get vaccinated. So I'd say midsummer is where hopefully we'll be at that point. What surveillance is done? Well, we do on a subset of specimens, the ones that turn up positive and that demonstrate either there's particular reason for concern in a region, or they demonstrate there's a certain pattern called an S gene dropout that shows up in the PCR testing using one technology platform. When that shows up, we sequence some of those samples, and that's how we found the ones in Northern Kentucky. The CDC and the federal government have messaged, though, that they want to invest a lot more money and expand genomic sequencing substantially using private vendors and state health labs and others. So hopefully that will also increase. And what's the plan to reach difficult to reach populations, those without computer, internet, disabilities, homeless? Well, the question itself belies the difficulty and complexity. They're not a uniform group. They're a very heterogeneous group. So the things that have to be done to reach the homeless are different than people without a computer, are different than people who have disabilities and are immobile, are different than people who live in communities, communities of color or communities of migrant workers, who work in some of our industries. Each one of those is its own solution set in some ways, and a lot of it has to do with helping them feel comfortable with receiving the vaccine. And then a lot of it also has to do with the current vaccines have been real tricky. If you thaw them and you take Moderna out in the field and you shake it up a lot, you can inactivate the vaccine. So you have to be cognizant of the limitations of the pharmaceutical. They just don't go everywhere the way everyone wants them to. But we're going to get better at that. And so there's a decided intentional focus on improving these things. And then let me answer these last few questions, and then I'll let you send us off, Joel, as I head to my 1 o'clock. But why are there multiple vaccines instead of one? Well, it's because no one knew what was going to work. And so everybody was developing concurrent with each other. And so you wanted to hedge your bets. You didn't want to have all your eggs in one basket, so to speak. You wanted to have numerous different possibilities. And so the great success here is that out of those possibilities, the federal government picked 6 as the horses to bet on, and the first 3 look like are going to work. That's fantastic. That 50-50 batting average for a vaccine is pretty fantastic. And so we needed multiple to hedge our bets. The One Health initiative is interesting. In my prior life as an American Medical Association leader, I had dialogue with some of the folks in One Health. It is important, the interaction between the humans and other species on the planet and what that interface is. And clearly that's a problem because we believe SARS-CoV-2 leapt from another species into the human species. That is very important. I will also just observe, for whatever reason, it's been incredibly difficult to get really robust, sustained dialogue across all of the parties that would be involved in One Health. And that doesn't mean that One Health is not doing good work and that there aren't a lot of dialogues, but it's like a lot of other things. It's hard to get it to the scale it needs to get. But yes, I think those efforts are important. For the masks, thinking about the use of masks, we weren't clear. You know, part of the reason in the beginning, and this is where communication is difficult in so many ways. I don't think anyone would wanted to, well, I don't think most people wanted to say, don't wear a mask because it may not help you and you're stupid if you do it. I think part of the problem was the only masks most people could get were medical masks, procedural masks, and they were and then the people in the hospitals didn't even have access to them. So it put the public in competition with healthcare workers who clearly needed them at a higher priority. And also, the evidence wasn't 100% clear. And you've seen it evolve from it protects me from infecting you, and then how it probably protects us both. And then it protects both. If we're both wearing it, the protective value is even more. And now I think that there's no doubt that that's what we need to be doing. And I think mask use is here with us to stay. It won't be everybody, clearly, but I think we will emerge from this with it more normalized. People who are vulnerable will feel more comfortable probably wearing a mask in public. And I suspect the Western cultures are going to adopt this a little bit more. And I'm going to answer the last one, and then Joel, I'll let you send us off. How was preventing the spread of COVID-19 implemented in the homeless population by government organizations? The homeless population is challenging in a lot of ways. I mean, I'm an emergency physician for 20 years of practice, a big chunk of it here in Lexington. This is difficult. And so local health departments spent a lot of effort and time trying to work with them to get testing out to them when we had testing to be able to get to them. Local health departments are working to try to help work to address vaccinating them. It's difficult when you have a 2-dose vaccine, though, right? Because some of the transient population is difficult to get. They don't necessarily come back for their appointments. Now, that doesn't mean people don't know the homeless individuals as individuals and where they can be found. It's not easy. And not only is it not easy, sometimes it's not possible to do it very effectively. So we certainly are going to work on vaccination to make sure that they have access to vaccine as a vulnerable population. So, but a lot more work ahead. So Joel, thank you very much, everyone, for having me here. I hope my thinking out loud and talking with you was of some interest, and I wish you the best in your competition. The fact that we are living through a real world instance of it right now makes it much more real and drives it much closer to home. So thank you, Joel, and now to you.
Thanks so much, Steve. Man, that was great insights. And I think the students for tomorrow, they're so much better prepared as they think through what they're going to be presenting. So yeah, invaluable discussion, and your insights are amazing. So thank you so much. I'll go ahead and sign out so he can get to his meeting, and we'll see you guys tomorrow, Saturday morning tomorrow.
Good luck, everyone. Thank you very much. Bye-bye.